Hello and welcome back to the Downsized. My name is Christopher Durham. Of course, I'm your lovely host. No, my wife is the lovely host, but she's not here with me today. Today I have Condi Carmack. Condi, welcome back, man.
Well, thank you, Christopher, for having me back.
Well, so many of you may remember we had an interview with Condi a couple of weeks ago, talked about Condi's own GLP-1 journey, and I teased that he would be coming back and doing some videos with us regularly. So this is the first of that series. He's going to tell you a little bit more about that. Before we do that, let me do the obligatories for the YouTube. So if you haven't already, please like and subscribe, hit that notification bell. That way, every time we publish something, it'll tell you. And occasionally we just go live randomly. You never know when that's going to happen. We also want to remind you, and Condi will do the same thing, remind you that we are not doctors. Okay, I'm certainly not a doctor. If you need personal medical help, please talk to your medical professional about your health care, your weight loss, your nutrition, whatever it is, because although we have lots of opinions, they're just our opinions, and you need a real doctor. All right, so that's all the obligatories. So Condi is back. Condi's going to kind of walk you through what we're going to talk about and what it'll look like over the next few times. So Condi, welcome back, man.
Thank you, Christopher. It's a pleasure to be here.
All right, so tell us what we're going to talk about, Condi. How's this going to work?
So the format that I wanted to introduce everybody to is called a journal club. And it's something that I have done, everybody in academia has been doing for years and years. Journal club is where people get together and they discuss a paper or a news article or something of interest. And it's a great way to kick off a discussion. It's meant to be a two-way discussion, talking about the good points and the bad points of articles or papers. So today I wanted to actually go back and talk about a paper that Christopher actually introduced about 12 days ago, and I'll get to that in just a second. But I, wanted to let everybody know this is going to be a journal club format where we're going to present a paper or we're going to present something in the news about health medicine as it relates to obesity. So what we're going to do is record this. Christopher's going kind enough to record this, and we're going to discuss it during the broadcast. I'm going to house all of the materials and information, PowerPoint slides, a summary at my website, and I'll give that to you in just a second.
And we'll put it in the description. So if you guys want to look at the description, the link will be there.
It'll be there, and you can go back and you can look at the notes and see the websites and my sources. I use a lot of AI to actually summarize the information. The AI is used to summarize, to take notes, and also it creates a podcast, kind of a discussion between two people who just kind of summarize it and give you a brief synopsis of what the paper or the article said. And we hope that, you will feed back to us comments and guide us into future topics. So I'm very passionate about this. We're actually going to bring up some of the comments that were made after my first broadcast and talk about that. So again, we are not doctors. We're researchers that know cancer biology, and we're just going to discuss the relationship between cancer and obesity. So if you are considering therapy or medicines, you should consult your physician. Again, we use AI and we make every effort to be accurate, but of course, the AI currently does hallucinate. It can go off script, and you should always check out any information yourself just to make sure. So that gets us to this point, and I would like to thank Michael Clayton, who actually sent this in. This is a video from a real doctor in South Africa that has gotten into the obesity issues, and he has produced about an hour-long video on the good points and the bad points of injectable, mostly semaglutide and Tirzepatide. But it's a really good place to start and to understand, the endocrine system and what's going on. It's very complex. He shows a lot of slides, a lot of scientific slides, but it brings up some really good points. So thank you very much to Michael for sending that video in. Second of all, where am I going to put all this? I'm going to put it onto a page on Cancer Obesity Connection.org, and you'll be able to go back, several weeks and download everything whenever you want. Again, we're going to be going over a paper, this journal club, which Christopher has already presented about 10 days ago. And here is the QR code for that. He spent about 20 minutes talking about, some of the good points and some of the bad points about the incretins that they studied in this journal article. So here is the journal article itself. Again, it was a Nature Medicine paper about a month ago that came out. And these are the authors, and here's the QR code. If you want to download it from the Nature site, it's completely free. And in fact, you can download all of the data and reanalyze it yourself if you like. So just to reiterate what they did, the high points, this is a Nature Medicine paper. They were looking at in the VA hospital system. The nice thing about the VA is that they have a lot of patients. This particular study looked at 1.85 million participants over a 5-year period of time. They were looking at 175 health outcomes, and we'll talk about those in just a second. The other interesting thing about this is that they did their statistical analysis in what they call a discovery mode, so that they were open to both the good things about the drugs as well as the bad things. It wasn't necessarily biased. So they tried to make sure that they were as fair and balanced in looking at these drugs as possible. They did have control groups. They do cite those, and that's actually part of the study. But the one thing you have to remember about this particular study is that they were all diabetics. Okay, so keep that in the back of your mind. So again, they were all diabetics. The VA is an interesting cohort, and cohort just means patient population. They're socioeconomically poorer than some of the other veterans with other healthcare coverage. They're predominantly over 65. They tend to be white. They tend to be male. So with those caveats, we'll look at the data. Again, they're looking at 175 health outcomes. And if you look at this is called a circular heat map, and it's just a very comfortable way to presenting the data. They have all of the 175 health outcomes around the circle, and then they actually kind of show the statistics, how important or how unimportant they were in the inner circles, and they go into this. They also divided up into 12 types of disorders or organs, if you will, including endocrine and mental health, neoplasms, of course, cancers are over here on the left. So again, what they found were 42 of these 175 health care conditions lowered the risk for the individual. They're in blue here in the outside ring. And then there were 19 that raised the risk. So these were bad. and these were color coded into red. And then there were 114 that you kind of see that they didn't even label, in black and white, that had no effect. So just to reiterate, the positive health outcomes, I'm not going to go into the negative ones. Again, they classified them into different categories. Brain health, heart health, and mental well-being were the ones that kind of jumped out at you as being interesting and novel. So they did see a lower risk of seizures, dementia, and even Alzheimer's disease. Now, what this means is that the GLP-1RAs can't necessarily cure Alzheimer's, but it could have a protective effect. So if you are at risk of Alzheimer's or dementia or seizures, you might consider going on this in the future. With regards to heart health, that's probably the most predominant finding in this study. The data suggests that there's a lower risk of heart attacks, strokes, and blood clots, and also deep vein thrombosis. So it's really fascinating to think that these drugs could be influencing blood clotting. So they're going to do a lot more research in this particular area. And then the third area, which has received a lot of notoriety recently, is the mental well-being. Interesting, the GLP-RAs were linked to a lower risk of things like suicide thoughts, bulimia, and even schizophrenia. So it's interesting that these drugs might be acting through neurotransmitters like dopamine and serotonin. How they're doing that, we don't quite understand, and people are going back and looking at the mechanism. But at this point in time, we just don't know how it's working. And then you might be interested in the GLP-1RAs that they actually used. And here's a list of them along with their percentages. So you'll notice that the main one of interest was semaglutide, right? So it was about 70%, followed by dual glutide, 14%, or I should say liraglutide, about 15%. So they were the vast majority. And then you actually see Tirzepatide, which was, at the second generation, was used a little bit, but just a touch. So it will be interesting to see them do this study in another 4 or 5 years with Tirzepatide being the dominant GLP-1 going into that study.
Well, so can I ask a question?
Please.
So when I look at, and I'm not a scientist, so I'm asking a scientist a question, and I may not sound very intelligent. I apologize. So when I look at those numbers, my head says semaglutide is so dominant in that list that it's basically washing out everything else.
Yes. Well, so you have to remember when this study was done, and it was actually started in late 2017.
Mm-hmm.
Semaglutide just came out at that time, or was FDA approved. Okay. So they don't say this in the paper, but what I have an idea is that they took the dates and they matched it to the semaglutide introduction. And then they went 5 years to get enough people into that cohort. So they started the study when semaglutide was approved, which was in December of 2017.
And honestly, some of those I've never heard of.
And right, exactly. So you have to remember that the incretins have been around since 2005, kind of a generation that didn't receive a lot of attention, but they were experimenting on making them last longer. You could inject the incretins, and then they just disappear because of proteases. So they have worked long and hard on trying to get incretins not to degrade and to last a week, because nobody wants to take 3 shots a day into the belly. That's just not going to work. Okay. So, the bottom line is that the pharmas are listening. So this is actually data from last Thursday, when Lilly had their investor call, and Dave Ricks presented, and he actually talked about Lilly opening up a phase 3 orforglipron in hypertension, so that's high blood pressure. Lilly is continuing their studies in heart conditions along with sleep apnea. So Lilly has just a ton of clinical trials coming out this year and next year and the year after with Tirzepatide and some of the newer incretins. Now, they also announced that they're doing studies in inflammation and also in SUD, substance use disorder. They didn't say what those were, but they'll probably be making announcement as to clinical trials within a couple of months.
Well, and so let's not gloss over that blood pressure one though, because the analysts got really excited about that.
Yeah.
Because if it gets if a daily pill GLP-1 gets approved for blood pressure, it opens up coverage to an astronomical number of people who have high blood pressure in the United States.
Oh yeah, without a doubt. So that is an interesting drug simply because it is oral. You take it every day. The oral route is not right now is not as effective as the injection. Okay. So it actually might be a combination of injections at the beginning to get the weight and the blood pressure down, and then convert people over to the oral medication to be taken every day.
And Ricks has said that he thinks it's very possible that over the course of a weight loss and health journey, he could see patients on retatrutide, Tirzepatide, and orforglipron. So depending on what their doctor needs and where they're going.
No, it's going to be a personalized thing for each individual, depending on what they need and how they need it, and the timing. Without a doubt, I think that this is going to be a game changer. The other nice thing, of course, about oral pills, besides they're easier to take, is that they don't need to be refrigerated. And so that's going to take a lot of the cost out of it, storage and things like that, that hopefully will bring the price down.
It's a lot cheaper to make. There's a lot of pill factories in the world.
There are, and it's a well-known science. Again, the dosage is going to be critical. How to get it through the stomach and the acids of the stomach, and get it absorbed and get it to the target organs is going to be very interesting as to how they do it. And then Novo, of course, is actually going to be continuing their interest in Alzheimer's disease with Wegovy, and that's a very large study, actually 2 large studies, and the results are expected out this year. So, in related news, something that actually happened yesterday, Lilly made an announcement that they were going to be co-developing drugs with a Korean pharmaceutical company treating MASH. And that, of course, is liver disease. It's not exactly cancer, but it's actually a liver disorder. And so that is very, very big, because Lilly is now thinking about combination therapies. And I'm sure that Novo is, and Amgen is, and everybody are thinking about what do they have in their portfolio that could be complemented with the incretins. So I give this a 5 out of 5 star review. And then if anybody's interested, you can sign up for our newsletter at cancerobesityconnection.org using this QR code. I'd love it. And
So
then
let
I
me
was,
ask a question first before we
please.
go into that one. So when we go back and look at, there were, I think you said 19 negative
Yeah.
effects, things that
Mhm.
they discovered out of this.
Yeah.
When we look at this study, if they did it again, I don't know, a year from now, 5 years from now, whatever, and there's a larger percentage of Tirzepatide in it, and there should theoretically be a larger percentage, they should be able to pull data on non-diabetics.
Yeah.
Is that an appropriate assumption?
Yeah. So the VA, I do believe, is giving Wegovy for obesity. I think I'll
So
have to check that. But Wegovy, is now being used on non-diabetic patients.
right. So theoretically, could they also parse out where the diabetes is causing the problem and where the diabetes and the GLP-1 stop and start? Does that make sense?
Yeah. Right now, the data I've seen is that the the non-diabetic population is the same as the diabetic population with
Mhm.
regards to all of the other health outcomes.
Right.
I don't think that there's going to be a difference between the two populations, but I could be wrong.
Well, and the one I think of the most, which if you dive deep into there, is the whole conversation around vision and ion and all of that,
Mm.
which is a very high instance rate in diabetics, regardless of whether they take GLP-1.
Right.
So, you know, where does what's actually happening there? And I don't know. I have no idea. But
Oh, you mean with regards to the mechanism of
yeah.
action or what?
So is it the GLP-1? Is the diabetes? I don't know.
Yeah, to tell you the truth, I don't know. I can look it up, but
Yeah, I don't think
right now,
anybody knows right now is the real answer, but
yeah.
awesome. All right. Well, let's see what Mr. Clanton says.
Okay, so the first comment that Michael made was that there's a blood test for cancer is set to replace colonoscopy for most. My doctor said about 2 years. I think your doctor is wrong, to tell you the truth. There is a blood test. It's out there. People have been using it for years. There are a number of companies that are bringing this up. The test is called, or the generic name is called ctDNA, which stands for circulating tumor DNA. It's very expensive. We're talking about $4,000 or $5,000 for this. The idea of the thing is that you have a tumor inside you, that is very small, and tumors die, cells die, and they release their DNA. They release their DNA, and the DNA floats around in the blood. So you do the blood test, you draw the blood, and what you do is you sequence the DNA and you identify it as tumor DNA or from a cancer somewhere in the body. So the problem that you have with that test is you know that you've got a tumor, but you don't know where it is. Well, that's a problem. So they can tell you that you have a cancer somewhere. And so now they've got to go look for it.
So you still have to
So
do the colonoscopy.
you still have to do the colonoscopy. So it's going to be a test. It's going to be out there. It's going to be publicly available. You can do it right now with Grail. Send them $1,000. They'll do it.
But this isn't a draw blood and look at it under a microscope. This is a
No,
DNA
it's
sequencing
a DNA.
elaborate thing.
Yeah, yeah. And
So
it's
this whole comment flowed out of, if you guys follow along, Lorraine has had a couple of colonoscopies over the last several months, and Michael was giving some commentary on it. We appreciate Michael. He's always got good stuff to say. But it's good. Thank you for sharing that with us.
yeah, no, I think that the ctDNA is coming along, but very slowly. It's not perfect. It will be added to all of the other tests that you do. So I think that they will draw your blood. I think that they will do the test. But it won't catch all the tumors, all the cancers, because some don't shed into the blood.
Well, and so to give color there, just for my wife, and Lorena will talk about it, so I'm not saying anything. She has a family history of colon cancer. Her grandmother died of colon cancer, and she's had not anything cancerous removed, but she's had several polyps and everything. So we just watch it very closely.
Yes,
I would much rather them just go in and take a look.
I agree, and also, of course, Cologuard is very good,
Yep.
but it's not for people at high risk like your wife.
Mhm. Well, we want her around, so we'll take her
Okay.
down for the colonoscopy. Perfect. What else did they say?
Okay, so Robin actually had a comment with regards to nope, it's not the estrogen, or everybody would have cancer. It boils down to inflammation. So, Robin, we agree on half of that. I think it can be both. I think it can be inflammation, but also the estrogen is driving some cancers, like breast cancer, like endometrial cancer, like ovarian cancer. So, it depends on the cancer.
Well, so remind me of what you said, because as I recall, there was something about premenopausal, postmenopausal, and how the estrogen worked.
Yeah. So one of the things that they try to do for postmenopausal women is to reduce their estrogen, and they give them drugs to actually lower the amount of hormone. Unfortunately, the drugs that they give you stimulate fat production. So instead of losing weight, you actually gain weight when you go on these drugs. Okay. So these are endocrine therapies that have been used for years and years and years. So it is known that estrogen does fuel cancer for breast cancer and for endometrial cancer and for ovarian cancer. These are called hormone-dependent cancers. Now, they're also now working on the prostate cancers. It is also believed to be a hormone-driven cancer.
Makes sense.
Okay.
Yep.
So let's see what else. So this is Mama Normal. Would like to know if Tirzepatide could be beneficial in treating inflammatory bowel disease like Crohn's disease or ulcerative colitis. And the short answer is yes. Both of these diseases are immune dysfunction. They're environmental, they're genetic, and they also um, work off of what we call the microbiome, which is your gut bacteria, your native flora. Um, so it's going to be probably a combination of autoimmune or immune modulation, environmental, changing your food. You can't change your genetics, unfortunately, but you can look at it and you can look for susceptibility genes. You can see if you are at potentially high risk for these diseases. I think that Tirzepatide will have its place in not treating the diseases, but actually preventing the diseases from occurring.
That makes a lot of sense, though. I mean, and I can tell you in my sample of one, so I don't have either one of those diseases, but I have a very active digestive system that prior to Tirzepatide just was explosive on many, many occasions of my life. Tirzepatide's just kind of made everything a little. Actually, that constipation people get helped me out.
Yep.
So,
Yep. Okay, slide 20. Got tag it? Expand on the connection between reduction in cancer and bariatric surgery. That's a great topic. There's lots of data. We've had bariatric surgery available since the late 50s, I believe. There are millions of people who have received bariatric surgery, and the numbers are incredibly accurate with regards to the reduction in cancer. I could actually dig some of these out, for a later topic and present them. But
that'd be awesome.
the data is solid that reduction in weight causes a reduction cancer risk. Okay. Let's see. Jerry says, do a topic on non-responders on these peptides. So that's an interesting question that has to do, of course, with genetics. And so we don't have all of the genetic information behind us, but it is something that people are curious about. So if you take any of these studies, and there have been a number of them, you actually get about 10 to 30% of non-responders, people who don't respond to the drug endpoint. And so we get into the issue of what is the endpoint. And many of these studies are looking at endpoints like A1C, and you give them the Tirzepatide and they don't achieve their A1C, but they may lose weight. So they may respond to one endpoint, but not the other. So it would actually be interesting to kind of go in, look at the genetics, and try to figure out, why there are non-responders, why the number is so high, 10 to 30%. One of the questions, of course, is, can you just give them more drug? Can you overcome their non-responsiveness by giving them more drug? Clinical trials are not designed that way to increase the dose. They're designed a certain way to get the drug approved by the FDA, period. They throw out those non-responders. They don't care about them.
Well, so let me ask a question, because I hear
Mhm.
this, I hear the non-responder thing all the time. Very often when we continue to ask them questions, it seems like their doctor perhaps did not level set what response was and what to
Yep.
expect.
Mhm.
So if I'm taking this medication, what should I expect?
Mhm.
And what actually would be a non-responder?
Right. So there are a couple of problems. Number one is what they call in clinical trials compliance. Taking your drug, the appropriate drug at the right time, in the right environment or the right space, whatever. So compliance is a big issue with regards to clinical trials. So the first thing you have to ask is, did they take the drug correctly?
Lorraine and I say the only real trick to this, the only tip you need to know is take your shot. Every week, take your shot.
Right. But shots are a problem because a lot of
Yeah.
people don't like them. Okay. And they may miss or they don't do it right. So compliance is a big thing. Let's just assume that everybody is doing it the right way and taking their shot when they're supposed to and stuff like that. Then you have to figure out, what is the endpoint? What are they looking at? Is it the A1C? Is it the weight loss? Is it, whatever number you're looking at? So you have to dig into the clinical trial and see what they were going for before you can actually say, you know, why are the non-responders non-responders?
And so,
Would they respond also to another incretin?
yep.
Okay.
And so what Lily says about Tirzepatide is that if you are a responder, you should be losing between 0.5 and 2 pounds a week on average.
Yes.
Doesn't
Right.
mean every week, but over the course of your treatment, so generally they're even saying a year, it's going to be somewhere between 0.5 and 2 pounds. So if you're responding,
Yeah.
if you're losing at all, you're responding.
Yeah. Well, in looking at the data, when they call a certain group non-responders, you look at it and they're responding. They're just not responding at the clinical trial level.
Yeah, we just get people that are like, well, I saw somebody on Facebook that lost 35 pounds the first week, so I'm not responding. Well, no, you're responding.
Yeah. Yeah.
You just
Yeah.
have you need to level set your expectation, because that's not what Lily said.
Right. We're all individuals and everybody is going to respond to these drugs differently, without a doubt.
And then you throw in the complication of diabetes, and honestly, as you say, the end point might be I need to lower my A1C, and I might not lose any weight, but I'm not going to lose a limb because Maybe
It's
when
all
somebody's got
relative.
3 points,
Yeah.
right?
Okay. Let's see. Love to know more about the connection between obesity and autoimmune conditions. Oh, well. Inflammatory markers, joint pain, RA, rosacea. Okay. Another great question. Of course, my background is immunology. I was a T cell and a B cell immunologist for a number of years. So immunology is a very hot topic these days. Autoimmunity, to tell you the truth, they still don't understand it very well. There is there are no good drugs for autoimmune diseases. What they usually do is give you a corticosteroid drug for a couple of weeks or a month, and then take you off of it, and hopefully your immune system has been suppressed and it doesn't come back. Many times it does come back, and you start the cycle over again. So there is a connection between obesity and autoimmunity, uh, between obesity and the immune system in general. Um, we are just beginning to scratch the surface. But I'd be happy to, dig into this and try to dig up some more information.
Well, and so, there's a lot of folks 'cause we get questions about lupus all the time,
Yep.
and I just say the same thing you said, is I haven't seen anything on that, but we watch. If we find it, we'll tell you about it.
Right. So I have an idea that they are going to be doing some preventative clinical trials, if you will, uh,
Mhm.
with people with lupus. Lupus, tends to be a female disease, and obesity does run in that cohort. So I think that they're going to be looking at the autoimmune and trying. And the nice thing, or the thing about immune diseases, is you can measure some of the cytokines, some of the lymphokines from blood. So you can kind of monitor it, and hopefully you'll see some of those go down. The inflammation and the autoimmunity go down. Autoantibodies would hopefully go down. Anti-DNA antibodies hopefully would go down. So there are those biomarkers that you could actually monitor.
So do you think, because we've done a couple of stories on some of these bigger AI models really taking out, entire healthcare systems, kind of like the VA's was, but
Mhm.
because they could look at it at such a high speed and be a little more, I don't know, intuitive is not the right word, but dig a little deeper. Do you think as we get more history, it's possible that some of those autoimmune things may pop forward?
Yeah. They definitely have a genetic component to them.
Mhm.
I think that now that we're sequencing people, we're going back and looking at their germline sequences. I think that some of that will fall out, either with AI or association studies, GWAS studies. Yeah,
Yeah, there's a lot of data stuff going on. It's going to be exciting, I think.
a lot of data is an understatement. Yes. Then finally, the last question. It's Michael Clanton again. There is an amino acid in the peptide that has DPP4 inhibition. And so does the whole chain act as a whole, or can it split and act independently? Well, this is an inside baseball question and really
Very
gets
much so.
into the into the weeds, but a great question. So semaglutide and Tirzepatide are manufactured as a single polypeptide chain. They're a single molecule. However, they're injected, and when they're injected, they're subject to proteolytic enzymes, peptidases, that can cleave the molecule. And in fact, you may want the molecule cleaved so it is more bioavailable. So the trick is to make this thing more bioavailable to the target organs. And there are a number of those. So the cleavage could hurt or it could help the bioavailability. I think the answer is going to reside actually in the patents, looking back how they manufacture these things. Um, Probably is not necessarily a trade secret because many of the compounded pharmacies are making this, and to make it properly, they need the recipe.
Yeah.
So this is part of the recipe that I believe is in the public domain, but I'll have to go back and check.
Yeah. So for those of you, the inside baseball piece of it, Michael's a science nerd, and Michael and I talk about this all the time. If you want to go, you can search on the USPTO database, and the patents are there.
Oh, yeah.
And they are hundreds of pages of science that are far beyond me. Hopefully, Condi could understand it. But if you really want to dig in, so that when you see one of these pens and it says Tirzepatide, water, and a stabilizer, or whatever it says, there's only like 4 ingredients that it says. Well, the stuff behind that is hundreds of pages of patent.
Yep. So I think Michael may be trying to start his own compounding pharmacy.
Maybe, I don't know.
Maybe we can get a discount.
It'd be nice.
Yeah. Okay. Well, I think that is it.
All right. Well, perfect. Well, thank you very much, Condi. Let me flip this. If you've seen research papers out there, if you've heard people saying crazy things on the internet, we need to debunk them. Okay, we can do all those things. And we'll do this journal club. I mean, I think it's one of my favorite authors are which isn't a science reference to your journal club, but it still works, is Tolkien and Lewis. So Tolkien and Lewis had a readers club, they were both professors at a university, and they would sit around and read each other's papers. And it turns out they turned into the Lord of the Rings and into Narnia, and same kind of conversation. So super exciting.
Good.
All right. So Condi will be back. If you want to leave anything in the comments, ask questions, topics, you name it. And Condi will take notes as you see, and you might see your comment pop up in a later episode. Make sure you go and visit his site. I'll make sure to put that in the description, so if you want the resource material and all of that stuff. But thank you very much, Condi.
Thank you, Christopher.
All right. Well, make sure to like and subscribe to the Downsized as always. We appreciate you watching. Again, we're not doctors, so make sure you talk to your doctor about your healthcare needs. And that's been us for today. Thank you very much, Condi. We'll talk next time.
Cheers.